I just want to say welcome to everybody who's joined us so far. This has probably been the biggest registration of people that we've had since our very, very first presentation. So we've got over 120 people registered tonight. So thank you so much, Nicole and Ben, for the time that you've put into preparing tonight. I'm really looking forward to it. And I know most people listening, or all people listening, are really looking forward to it as well. Certainly anytime we talk about osteoporosis or bones, people jump on board. So in hoping that we might get a few more people on in the next couple of minutes, what we're going to do is just pop a little poll up on the screen and get everyone to answer a couple of questions. And these questions, thanks very much, Carlo, for doing that. These questions relate to osteoporosis. And so for most of you, there'll be questions that you can answer pretty quickly. The reason that we want to get this is to get a bit of an understanding for Nicole and Ben about where our audience is currently at. So do we have a big audience here tonight who's got osteoporosis? Do we have a big audience that's got osteopenia, or have we got people who are just interested in bone health? And what's our compliance like with DEXA scans, which is question number 2. No, I haven't had a DEXA scan in the last couple of years. And yes, I spend most of my day in close proximity to a couple of exercise physiologists, so I can answer yes to the last one for sure. We'll let everybody get through those answers, just teeing up to 90 people. And Carlo, when we reach about 80%, can you let us know, and then we'll pop those results up on the screen?
Just actually clocked over, so that was one of our.
That was pretty quick. Oh, well, give everyone another 30. Oh no, I don't need another 30 seconds. So, do you have any of the following? Normal bone health, about a third osteopenic, and a little bit over a third osteoporotic, and definitely a few people who are unsure. A definite majority of people who've got DEXA scan, who've had DEXA scans in the last 2 years, but also a big portion of people who haven't. And I'm sure Ben and Nicole will address how often we should be having DEXA scans. And have you ever seen an accredited exercise physiologist before? 3/4 of people saying no. So certainly an opportunity for you to learn tonight a little bit about what an EP does and how they can help in the osteoporosis setting. So Ben and Nicole, I'll get you guys to share your screen if you can, and then welcome everybody. Ben and Nicole are both accredited exercise physiologists. Ben at Keyser Brighton, Nicole at Keyser Malvern. Both of them are currently seeing clients at the moment online and in the centres as well, because our allied health centres, Keyser's been able to stay open over the last couple of months. And I'm going to hand it over to you guys now to take us through everything that we need to know about bone health. Thank you and good luck.
Thank you.
Beautiful. Thank you for the kind introduction, Tim. So as Tim said, we'll be presenting tonight on bone health, and thank you all for joining us on this Wednesday evening for another fantastic Keyser webinar. As Tim mentioned, my name is Ben. I'm an exercise physiologist from Keyser in Malvern, and presenting with me is Nicole, exercise physiologist from Brighton and Malvern. So before we kick off, I also want to let everyone know what it is that an exercise physiologist is and what we do here in the clinic at Keyser. Our role is to use exercise as a therapy to treat and to manage any kind of chronic disease or chronic illness. This can include conditions such as osteoporosis, osteopenia, diabetes, cancer, and any form of cardiometabolic or neurological condition. So the agenda for tonight, we're going to kick things off with talking about bone structure and function. We're then going to go through the prevalence and some risk factors of bone disorders such as osteoporosis. We're going to look at the risk of fracture and introduce you to a term called the fracture cascade. We're going to go over how osteoporosis is diagnosed. Nicole will introduce you to a term and a process called bone remodeling. We'll then go over treatment options, primarily the exercise prescription, and then we'll finish off with what's happening with Kiza. So looking at the structure of a bone, you can see here on the right, we have a picture of a long bone. On the outside of that bone, you can see a thick, dense portion of bone. That is referred to as a cortical or compact bone, okay? Now, the role of that is to protect against any form of bending or twisting force applied to the body. Inside that compact bone, you can see what's referred to as spongy bone, which is all those little lines in that dense bone together. That's protection against compressive loads and acts as a bit of a shock absorber. You can also see there throughout the bone, there is blood vessels and nerves and some bone marrow in the center. So these two forms of bone, they work together to support and facilitate movement throughout the body. Our bones help to protect our vital organs, particularly our heart and our lungs inside our rib cage. Also have the role of storage of minerals and the production of blood cells. So before we move on, I'm going to do a little bit of a pop quiz for everyone. So I know that you guys can't answer me, but I'm going to give you a few seconds to have a think about it. How many bones are in the adult human body? Give you about 5 or 10 seconds. Tick tock, tick tock.
Ben, not everybody has the luxury of turning on their mic and video like I do. But I should have mentioned at the start, if anybody has a question, they do have the capacity to chime in with a question. If you just enter the Q&A down the bottom, Carlo and I will track that, and I'll chime in and ask Ben a question. So I don't have an answer for your question, and I'll let you get to it, Ben, but I just wanted to make sure everybody knew that they could, if they wanted to, ask both you and Nicole a question.
Fantastic. Thanks, Tim. So there is 206 bones in the adult body. We are born with 270 at birth, but throughout childhood and adolescence, quite a few bones fuse together, and we are left with 206. So there's a bit of dinner party trivia for you at your next Zoom drinks with your friends.
All right, so moving on to what happens to us over time. So I guess with the natural process of aging, we do lose, I guess, both muscle mass and bone density as well. In general, you are going to lose a bit of fitness. Obviously, your joints go through a bit of wear and tear, depending on what types of exercises you are doing. Often flexibility is also reduced, but also, as generally speaking, we do become less active as we age as well. Statistics wise, after the age of 30 years old, you do lose per decade about 3 to 8% of your muscle mass. Unfortunately, when you hit 60 years old, that decline does actually, decrease, or you do lose your muscle mass a lot quicker as well. So it is really important that you can actually, slow down this process through the participation of the kind of strength training and the right type of exercise intervention as well. So bringing us to the next slide, this is probably one of the most important ones. So on the y-axis, so the vertical line, you've got your bone mineral density, and then on the x-axis, you've got your age in years. As you can see, it goes up by 10 years each time. Represented in the pink, you've got females, and then represented in the blue, you've got males. So with both genders, sorry Tim, I think you're going to pop up with the question, you reach your peak bone mass at around about 30 years old. From that age group, like I said previously, we do actually start to lose that bone mineral density as we age. With females, when we hit, menopause, whether it's early onset of menopause, with the change in hormones, we do actually lose a lot more bone mass. This is due to, the change in hormones, and unfortunately, we cannot absorb that calcium into the bones. So depending on where you do, hit menopause, that does accelerate the bone loss.
Nicole, I did pop up because I have got a question. Firstly, as a 33-year-old, I'm rapt that my bone mass is peaking. That's made my day. But secondly, it looks like a pretty significant decline for males and females. So is it a decline for everybody? Can I flatten it out? Can I reverse it? Or is it just going to be a decline inevitably?
Yep. Well, overall, unfortunately, there may be a decline, but you can actually reverse your bone loss. Obviously, it's going to be extremely individualised, depending on what kind of interventions you have, whether it's exercise-based or depending on whether you're osteoporotic, depending how severe that is, maybe a combination with medication too. Bone is a living tissue, much the same as muscle, so you can actually build upon it. Again, it is going to be very individualised and it will be kind of a long-term process. With any intervention, the main goal and aim is to reduce that bone mineral density loss. If we thought about, again, having a DEXA scan and then 2 years later, maybe your bone mineral density was much the same, that would probably be, I guess, a bit of a win, maintaining that strength of your bones.
Yeah, so that's what I'm taking out of your answer there, is that if me or if a patient is able to maintain their bone density,
Yep.
then because of what would happen naturally, that's a win. Like, maintenance is a win.
Yeah, totally. Especially over that period of time as well. So I guess we'll explain it during, I guess, the further presentation. We'll try and encourage everyone, regardless whether you are diagnosed with osteopenia or osteoporosis, to undertake, I guess, an optimal bone loading program. But great question. Thanks, Tim.
Okay, so we've talked about bones and we've talked about the loss of bone density over time. So that leads us to osteoporosis, which is that progressive loss or that advanced loss of bone density as we age. And osteoporosis simply means porous or more brittle bone. And this happens when there is an imbalance between minerals in the body. So they're not being replaced as fast as they are being used up. Unfortunately, it is a silent condition. So unlike other issues, other conditions or injuries, you're not going to feel any pain, you're not going to feel any numbness or tingling. So it can go undiagnosed for a long period of time. So therefore, it is recommended that over the age of 50, everyone does go and get a bone scan because it's so important to get onto it as fast as possible. And as we know, that increase in, that loss of bone density and the more brittle the bones are, the increase in that risk of fracture. And we'll touch on fractures a little bit later. So as you can see here, we have a picture of, looking at the left, a normal bone on the top and an osteoporotic bone on the bottom. So I hope everyone remembers what the two types of bone are. But as you can see on the top bone, around the outside, our compact bone, you can see that's nice and thick, nice and solid. The spongy bone in the middle, it's very dense, tightly packed together. So a good normal functioning bone. And then the one underneath is the osteoporotic bone. So you can see how that cortical bone has really thinned down. And the spongy bone has, it's less dense, it's more dense, it's more porous. Therefore, the ability for that bone to withstand both compressive, tensile, and shearing forces is going to be significantly reduced and therefore increase that risk of fracture in the future.
So moving on to, I guess, a few common misconceptions, whether you've heard this from friends or just, I know, heard it through the grapevine, we'll just run through, I guess, a few of them. So number one, osteoporosis isn't that common. It is very common and very prevalent in Australia. We've got over 1 million Australians who are diagnosed with osteoporosis and then 6 million Australians who are diagnosed with osteopenia, so just below average. Like Ben's just kind of touched on, it is a silent condition as well. So it is unfortunately the case of maybe many individuals out there in the world or within Australia who are going, I guess, undiagnosed until maybe they have a fall or a fracture, which then actually encourages them to be, I guess, referred on for a DEXA scan to then be diagnosed officially. Number two, osteoporosis doesn't affect men or young women. That's also wrong. So 1 in 6 males over the age of 60 years will be affected, and then in females, 2 in 3 females over the age of 60 years will also be diagnosed. In young women, they can be at higher risk due to specific health conditions. So, for example, they might be celiac, they might have breast cancer, they might have eating disorders, or they might be taking some, I guess, corticosteroids, so medication that might also increase their risk. Number 3, if you have osteoporosis, it's too late to protect your bones from fractures. So coming off the question that Tim asked, again, bone is a living tissue, so you can actually build it up much the same as muscles. It is just really important that you are doing the optimal bone loading exercise program to maximize that, or at least maintain that strength in your bones. Number 4, participating in walking and swimming is enough to prevent fractures. Again, this is untrue in relation to fractures. Both swimming and walking are really, really great for, I guess, aerobic capacity, maybe a bit of strength, a bit of flexibility, but unfortunately specific to your bone loading, it isn't going to be enough to really stimulate bone growth. So here are, I guess, a few common risk factors. Again, there might be a number of genetic factors or lifestyle factors that may influence your bone health. Genetic-wise, it might be gender, so male, female, medications that you're on, whether it's through cancer treatment or, again, steroids. You've got vitamin D exposure, so how much, I guess, you get outdoors, particularly when the sun's out. You've got age, and then you've also got body shape and body size and type as well, or kind of the build. Then we move into lifestyle. So whether you're active or maybe you're sedentary, you don't, I guess, reach the Australian activity guidelines, maybe you're a smoker, maybe excessive alcohol intake, and also, I guess, another one is obesity too. So some people find that obese individuals might actually be protected against osteoporosis. Recent research has actually demonstrated the hormones associated with obesity can actually impact your bone health as well. So they're just a few, not all, risk factors.
Nicole, just talk me through the obesity one again, about whether obesity is protective or a risk factor.
Yeah, so it's probably, I guess, a combination and might be quite individualised. So I guess more so a protective measure or protective kind of factor is because they have larger muscle mass or, I don't know, fat mass, I guess, when they are doing activities such as climbing stairs, that they are actually loading up the bones a lot more than maybe a lean individual. And then you've got the other hand, unfortunately with I guess obesity, with the increased risk of, I don't know, developing diabetes, you actually have maybe elevated hormones that then may influence your bone density and the strength of it. So yeah, I can't really tell you an answer there. It's either it helps you, but then of course obesity is also a chronic condition that we want to prevent long term. Hopefully that makes sense.
Yeah.
Thanks, Tim.
Perfect. Moving on, we're going to look at fractures. So as you can see here, highlighted is the wrist, the spine, and the hip. So these are the most common sites of fracture, particularly in those with osteoporosis. In the spine, it's primarily the lumbar spine, which is the most prevalent to fracture. When you do get or have a DEXA scan, the lumbar spine and the hip are the primary areas that they will test. And if they require a third test, they will also test that wrist and forearm area. So that leads me to the fracture cascade. So what this refers to is that once you have a fracture, the risk of fracture rises exponentially. So research has shown that a female who experiences a fracture is 4 times more likely to experience another fracture within the next 12 months. That's very significant. So we want to make sure that every step is being put in place to prevent that initial fracture from occurring. So looking at early diagnosis, keeping an active lifestyle, and eating a proper diet. If you have had that first fracture already, then we need to make sure that every treatment modality is being utilised, particularly exercise, to make sure and prevent that next fracture from occurring.
So that brings us to the diagnosis. So I guess the question at the start, I think most of you or a high percentage of you have already had a DEXA scan. So it is the gold standard, more so to measure your body composition, but particularly to measure your bone health. It is unfortunately the only measure out there to assess your bone health. It stands for a dual energy X-ray absorptiometry. Yes, got it. So it may take up to 10 to 15 minutes, and you do need to get a referral often from your GP to get this DEXA scan. Depending on age-wise or risk factors or health conditions, you can actually get, I guess, that referral quite easily, but also Medicare can actually be rebated as well. So we know if you're over the age of 70 years or have had a previous fracture as well, often you can get a DEXA scan. That brings us to where to get a DEXA scan. So you can get a DEXA scan at a hospital or a radiology centre or clinic. How often to get a DEXA scan? So generally speaking, it should be recommended to get a DEXA scan or a repeat every 2 years. If you are on a specific intervention, whether that's exercise-based for 12 months, or whether that's medication, or whether it's a combination, we would love to recommend to be repeated after 1 year. Although you might not see drastic changes, that's still going to be, I guess, the best measure for us to address and see and assess whether your bone health is either being managed or whether it's been, hopefully improved.
So is that, Nicole, is that realistic to see changes in bone density after 12 months?
Depending on the individual. Like we said, we can't promise you're going to make improvements. It is going to be very individualised, but maybe you might see maybe a 1 to 2% in your bone density improvement within that 12-month period. But again, there's a lot of factors that can contribute to that. So fingers crossed, if you're doing the right things, we're hopefully going to see more of a management and maybe even better an improvement.
So I've got 2 questions from our audience, guys, which I probably should have been a little bit quicker on. They might be 1 or 2 slides too late. But Jackie Gibbs said, I'm 55, a slim build. I fell in December and had a fracture of my femoral neck. Learned recently I have severe osteoporosis. I've been prescribed medication, but can I reverse this naturally with exercise?
Yeah, well, it is going to, as I said, it is very dependent. If your specialist has prescribed you a specific medication or treatment, I would go with what they have said, but there's definitely room for exercise to assist with that as well. So making sure you have an individualized program made up of various forms of exercise, which we will go through shortly, is the best way to approach that. There's no guarantee that it will reverse, but as we mentioned, the main goal is to just maintain what we have and prevent any further loss. Because osteoporosis is a naturally progressive condition, we want to just slow it down as much as we possibly can.
Jackie, Ben answered that very, very diplomatically. So I'm more willing to go out on a limb on this one and say, if you've been diagnosed with osteoporosis, one of the first treatments that you should undertake is exercise. So sometimes that's with medication, sometimes that's in the absence of medication, but I cannot think of an example of someone who's got osteoporosis who shouldn't be undertaking some degree of exercise. I've got another question for you, Ben, just a stat on the fracture cascade, which I think was about the risk of fracture increasing. Meredith Rogers just asked if you could repeat that for us, please.
12 months.
Yeah, it was. There was the research has shown that if a female experiences a fracture, then they are 4 times more likely to experience another fracture in the next 12 months.
Fantastic, thank you. And one more question from Angela Stanley about risk factors. Is being outdoors a risk factor or is it beneficial?
Definitely beneficial, depending on, I guess, what the UV are or UV is as well, but more so in relation to the vitamin D, I guess getting that into your system as well. I know you can, or Ben will cover it a bit later on as well, whether supplements is something that is recommended, but that's going to be more so from your GP as well. So yes, not a risk factor, but hopefully a good one to improve your vitamin D. Coming back to the DEXA scan, another really important thing is to ensure that you have the DEXA scan at the same facility and on the same model as well. Unfortunately, it's quite common that people get stuck, or whether they're recommended to take, I guess, a DEXA scan at one facility and then they have it at another. Unfortunately, you cannot compare those results. It's much the same comparing these apples and oranges.
So once you have that DEXA scan, you may be given a report that looks like this. Your specialist or your general practitioner may explain the results to you, but if you bring it into the clinic, your exercise physiologist will definitely go through it with you. The main thing we're looking at with this type of report or scan is what's referred to as the T-score. Okay, so as you can see there, the T-score compares your bone density to that of a healthy 30-year-old of the same sex. Okay, so it's comparing it against, you know, the gold standard of someone at their peak bone health. There's also a reading called the Z-score. Now, this compares your bone density to someone of the same age and body size. And we often get the question as, well, why aren't I tested against someone who's the same age as me? And I guess the answer to that is normally because these DEXA scans are done, you know, over the age of 50, 60 plus. If you're comparing it to your age group, then the majority have a lower bone density, so it's not going to be a very reliable reading or a very reliable measurement. The Z-score is primarily used for those who are a bit younger, maybe in their 20s, 30s or 40s, as Nicole mentioned, may have secondary osteoporosis due to a pre-existing condition or due to any kind of medication or treatment, where comparison against their own age group would be more appropriate. If we're trying to understand what that T-score means, you'll get a score between -4 and +4. So ideally, you want to be in that green zone there, from about -1 up to +4 in that normal bone health range. In between, so from -1 to -2.4 is what's referred to as osteopenia. You may have heard that term before. It just refers to low bone density or pre-osteoporosis. And then once you reach that -2.5 mark, that's when you are diagnosed with osteoporosis. And the further down that scale you go towards -4 refers to a further level of degeneration or loss of bone density within the body.
All right, that brings us to the bone remodeling cycle. So we've got two types of cells within, I guess, the body. You've got your osteoclasts, which break down the bone, and then we've got your osteoblasts, which build the bone back up. So your bones are constantly rebuilding. That's really important to note here. As you can see in the diagram, the purple, I guess, little blobs here are the osteoclasts. And then as we move across the timeline, we've got the osteoblasts in the light blue, which actually ensures that reversal does occur, and you can actually improve that mineralization, or I guess have additional mineralization. The best way to explain this is, I guess, a bit of a building analogy. If we're thinking about some brick layers, as you can see down the bottom, if we consider maybe, I guess, the ones on the left-hand side as your osteoclasts, so taking the bricks off the wall, so the old bricks off the wall, and then we've got the builders on the right-hand side, which are the osteoblasts. They're actually grabbing new bricks and placing them up in the wall. So this is occurring at the exact same time, but what we could say here is maybe the guys on the right-hand side, for the osteoblasts, if they went on maybe an extended coffee break or was slacking off or something like that, what occurs here is the osteoclasts, so the guys on the left that are taking old bricks off, are working at a faster rate than they're putting the new bricks up. So obviously with that imbalance, you're then going to lead to obviously more porous bones. So that's what's known as bone remodeling cycle. And again, we can reverse that bone loss, which is, obviously a huge positive.
Nicole?
Yes.
Why does that imbalance between the osteoblasts and the osteoclasts start to occur? We're getting a few questions on our Q&A specifically about, can I reverse this? So I've been diagnosed with osteoporosis, or I've been diagnosed with osteopenia, and people listening saying, can I reverse this? And I know the answer is it depends on the situation, it depends on the individual. But I just think it's important to touch on that point of that imbalance, the things that affect that imbalance. Sometimes we know them and so we can affect them, and sometimes we don't necessarily know them. So when you guys get asked the question, can we reverse it? the answer is, well, we don't know, but here are the things that we have to do to find out?
Yeah, definitely. So I guess through our, knowledge of exercise prescription as well, particularly at working, at Keyser, having the state-of-the-art machines, we can actually prescribe, the most optimal program, hopefully within Australia. What our aim is to target those common fracture sites, create, that strength and stability around those common fracture sites. So what we do is by strengthening up the muscle groups around those areas, those muscles can actually start tugging against your bones and hopefully stimulating, an increased activity of those osteoblasts. So I'll explain it a little bit further down with the role of medication. That's pretty much what medication does. It slows down those osteoclasts and it speeds up the osteoblast. So in fact, we're trying to use exercise as that kind of medication to hopefully create, greater activity within those bone building cells, activated through, exercise more so, strengthening up those muscles, but also loading those bones up accurately and safely too. So hopefully that answers it.
Right. Moving on, we're I'm just going to briefly touch on some of the most important nutrients for your bone health. So the first one is calcium, as I'm sure most of you are aware. It's found, like 99% of your calcium is found within your bones. Its role is to help with the building of bones within the body. It assists with muscle contraction, so important for when we're exercising. And it assists with nerve signaling, so sending any messages throughout the body. Primarily found in dairy food or supplementations. Now, I would be cautious with supplementing calcium unless you have been recommended by a dietitian or your GP to start taking calcium supplements. I would get a blood test first because there's only so much that can be absorbed during the day. And if you're taking mass amounts, it'll just be excreted out and you'll be wasting your money. So just make sure you are, or you are told when you need to have that. There are some factors that can affect the calcium absorption, such as low vitamin D levels. So we know that vitamin D and calcium work really well together to maintain our bone strength. Excessive caffeine or alcohol can also impact the effect of calcium and the absorption, as well as certain conditions and certain medications. And secondly, as I mentioned, vitamin D assists calcium for bone growth and assists with the absorption of calcium. A pretty significant statistic is that 30% of Australians are actually deficient in vitamin D. Okay, so one of the easiest ways to get exposure is through sunlight. I know it's a bit challenging in the winter, but when those sunny months come around, make sure you get outside and stay active. And they can also be found in oily fish as well. Do you have a question?
How relevant is sunlight at the moment, given, a lot of people probably feel like that they've been stuck inside for the last couple of months, Ben?
Yeah, look, it's massive. So if you feel like you haven't been getting outside enough, definitely take advantage of any of the last sunny days we have throughout winter. If you are worried about your vitamin D levels, you can get a blood test from your doctor and look at where your levels are on that scale. And if needed, they can get you to supplement it. We do know that rates of vitamin D deficiency do always increase during winter, especially during isolation we've had as well. So.
And so Rachel, Ben Ennis's partner, wanted to know, is there any signs that you might be developing osteoporosis, or is DEXA scan the only way? Is that relevant when you're talking about that vitamin D test?
Potentially. I can't really say one way or the other. There's no real, obviously there's no symptoms for osteoporosis. If you are very vitamin D deficient, like extremely, it's potentially that it could put you more at risk of osteoporosis. But I would leave that to your general practitioner or specialist to make the call on whether you need a bone scan on that one. One last thing to note before we move on from diet and nutrients. As part of our role and an exercise physiologist's role within Keyser, we can give general advice and recommendations such as what I've done in regards to diet and nutrition for a chronic disease. However, it's not within our scope to provide or prescribe an individualized meal plan for anyone. So if you are interested in that to supplement your exercise program, I would get in touch with an accredited dietitian.
Or we can refer on. All right, so medications. So we've kind of discussed the types of cells we have. So the osteoclasts, which break down the bone, and then the osteoblasts that form the new bone, which we try and activate, I guess, through exercise and stimulate them. Medications work in a way to reduce the osteoclast activity and therefore to maximize the osteoblasts, so ones that build up, I guess, the bone. Therefore, it's going to lead to improvements in your bone strength and hopefully prevent the loss of bone, or hopefully at least slow it down. So again, it is really important that you do seek, I guess, medical advice through this. Depending on the current situation you're in, maybe conditions, etc., your GP is going to be the most knowledgeable here.
Nicole, so you might have just answered that question for me, but Kerry wanted to know, I've heard that taking a calcium supplement might increase one's risk of cardiovascular disease. Any comment on that one?
Yeah. I know we had a Professor Peter Ebling, who was an endocrinologist. I can't remember from his presentation what the, I guess, risks are in relation to that. So yeah, I can't answer that. Ben?
Yeah, I'm not 100% sure either. I think for a lot of those side effects with supplementation and medication, they are quite small risk. So if someone has prescribed you that supplement or medication, I'll just flag it with that specialist.
Yeah, surely they have to go through the side effects as well. But yes, I'm unsure about that. Sorry.
All right. Now for the good stuff. What we've all been waiting for. The optimal bone loading exercise program. So we're talking about exercise for our bones. There's not just one mode of exercise that's better than anything else. It's a combination of multiple exercise modalities that's going to get you the best results. And when we talk about exercise for osteoporosis, we're talking about the osteogenic capacity, which is the ability to promote bone growth that exercise has on the body. So number one, we have progressive resistance training, as done at Keiser, which is fantastic for loading the muscles and the structures surrounding the bones, but also loading that external force through the bone itself. There's also another form of exercise called impact training, which we'll cover in detail, but that can be more low-level impact, such as weight-bearing exercises, or more high-level impact, such as plyometric type exercises. And then there's also balance. We know that balance, similar to strength and your bone health, does decline naturally with age, therefore increasing risk of falls. And if you are osteoporotic as well, therefore increasing risk of fracture. So we need to make sure we get onto balance as soon as possible. You can see on the right here, we have a little table looking at the osteogenic capacity of various sports. So you can see the sports that are very high impact, basketball, aerobics, tennis, gymnastics, very good for the bones. Down the other end, you've got things like swimming and cycling and leisurely walking, which are fantastic modes of exercise for your physical and mental health, but don't have the best effect on bones. So we're going to start with in-depth look at progressive resistance training. For those of you that like a definition, it is a method of increasing the strength of a weak or injured muscle by gradually increasing the resistance against which that muscle works, such as graduated weights. And I think the really important part of that sentence right there is the graduated weights. They need to be progressed. They need to start at a level that is adequate and safe for that individual, and then slowly progress over time. They're often completed using free weights and machines, and you can use other things such as dumbbells or medicine balls or resistance bands, or even your own body weight to load those muscles. But we know that machine training is one of the most effective modes of progressive resistance training. Some of the primary benefits we have: increased strength and muscle mass, reduction in visceral fat, which is that internal fat that sits around your organs inside your abdominal cavity, increased in bone mineral density. They're also seeing a reduction in blood pressure and blood glucose levels. So for those that have any cardiometabolic comorbidities, there's that added benefit as well. And we can also see a reduction in joint pain and wear and tear in the body. So the most appropriate prescription for resistance training is to start with at least 2 sessions per week. And that's really important. The frequency is one of the most important parts, because you need to apply a stimulus to the bone and the structures surrounding the bone. We need to give it time to rest, and we need to apply that stimulus again. And we need to keep hitting it frequently enough in order to see significant adaptation and change over time.
And when I progress to 3, can I then progress to 4, 5, 6, and 7 days a week as well, if I really like it?
Yes, good question, Tim. So we say when possible or when able to progress to 3 times a week. And we'll say 3 times a week is probably the maximum, or is the maximum to undertake of progressive resistance training, because you need that time for the body to recover. If you're not allowing time to recover, you're actually going to increase your risk of injury, and you're going to not have a significant strength gains over time.
And Ben, if I train once a week for 12 months, or if person A trains once a week for 12 months and person B trains twice a week for 12 months, is there a tangible or a measurable difference? Like, can you tell me that I'm going to increase my bone density by 5% if I do it once and 10% if I do it twice?
Unfortunately, I don't have a percentage figure for you, but we do know that training once a week, although it is still much better than doing it 0 times a week, is not going to give you the added benefit of doing it twice. I'm unsure if it'll give you 50% more value, but it's definitely going to have a much bigger impact on your bones and going to give you every chance to have a positive result at your next DEXA scan. On top of the frequency, we want to make sure that we're targeting all major muscle groups, especially those that cross or surround those common fracture sites that I mentioned earlier. And that's really, really important. We also want to monitor the intensity closely. And this can range from low intensity to high intensity. And your exercise physiologist will determine that level of starting intensity for you, but it will mostly be dependent on your previous exposure to strength training and your exercise history, as well as any injuries or comorbidities that you might have. But we always want to get someone to get to a higher level of intensity where possible, because all the research backs much greater benefits from a higher level of intensity over a lower level of intensity. We want each session to range from 30 to 60 minutes. And it's really important that you see an exercise physiologist from the get-go. Do you have a question, Tim?
Oh, no, you finish that sentence, Ben, and then I'm just going to jump on my soapbox for you guys in a second.
It's very important that you see an exercise physiologist from the beginning to get you set up with the most individualized and specific program for you, because there are certain contraindications and considerations that need to be taken into account when prescribing that first program. And there are certain movements and activities that also need to be avoided.
Thanks, Ben. What I was going to say is, for everyone listening, I'm only a part-time MC of Keyser webinars. I work as a physio during the day, and it breaks my heart when I have patients come in to see me as a physio with a vertebral fracture or a hip fracture or something, and they have been told, oh, you can't go and do exercise because your bones are osteoporotic. So the only thing I'm going to dispute in this exercise is the refer to exercise physiologist needs to come right to the top. So if you know that you've got osteoporosis or osteopenia, you can exercise. I've not seen a patient in my 15 years of practice as physio who's got osteoporosis who I can't get doing an exercise program, or we can't get doing an exercise program. But please start by seeing someone and get it safe from the start. And you will be surprised what you're able to do and how hard you're able to work with the appropriate exercises. But if you're not given the appropriate ones, even a really light load or even a really small volume of exercise can be detrimental and can be risky for these conditions. And unfortunately, I see the consequences of that as a physio, of someone who's tried to start an exercise program by themselves. And if everyone could just see an EP to start off with, you'd be able to do it safely and you would get a good result. So I just want to move your refer to exercise physiologist to the top, Ben. That's all.
Beautiful. Thank you.
So weight-bearing exercises, very short definition, forcing you to work against gravity. So some examples, you've got walking, hiking, jogging, climbing stairs, playing tennis and dancing. Moving on to the next one. So plyometric or impact exercises. So they are quite different to the weight bearing. So the definition of this one is where muscles exert maximal force within a short period of time. Stretching of the muscle before immediate contraction. So examples here, we've got running, hopscotch, so more hopping, and then skipping as well. So it is really important here that with this, I guess, prescription from the EP or exercise physiologist, that it is actually progressed continuously, and you do actually add a bit of variety in as well ongoing to, again, kind of change the angle of load and pulls within the muscles, but also loading through the bones too. An example we might use is, I guess, jumping on the spot. So just jumping up and down to maximize that or to improve it or to increase the kind of load, or you could get you jumping down from a higher step and then onto the ground. So the force is going to be, or the impact is going to be a lot greater.
Might demonstrate one of those for
Yeah,
everyone.
go for it, Ben.
So this is an example of some impact of plyometric exercise that we can do. So jumping up onto the box and then absorbing that force as we come down. I hope you can all see that. I'll do it one more time.
Nice, soft knees. Good job, Ben. Thanks, Ben. All right, so here's a common, or a question that we had come up.
Nicole,
Yes.
Nicole, just before you go to that one, Caroline just asked, can you give an example of higher intensity elicits greater benefits? And I think I just wanted to point that out live, that I think Ben's probably just demonstrated it, that going for a walk has relatively low impact on your bones, but doing the hopping task that you can see on the screen or the jumping task that Ben just did is a really good example of a higher intensity exercise, more load, and you would definitely get better benefits from Ben's exercise than just going for a walk. So
Thanks, Ben. Another good example is, yeah, if you're just jumping on the spot, I guess further down the track, if you want to change kind of the angle of load, you might maybe do a star jump instead. So that's another example. Here's a question that came up, so we'd love to answer this one. If impact and weight increase bone in exercise, how can this be done safely with a person who has had multiple prolapsed discs in their lower spine and has a bone mineral density classified as very high risk of fracture, so a T-score of -3.8. It seems counterintuitive to do any movements such as jumping that would put repeated pressure on these discs. So that is a very valid question. It is extremely important that, yes, we need to know or go see your exercise physiologist. We will educate you on this, but having a T-score of -3.8 is quite severe. It is really important that any jumping, any impact exercises are contraindicated. The good thing is exactly what Tim said, is we can make, I guess, an action plan initially. What we'd probably ideally look at is working on more specific, isolated strength training to begin with, hopefully building up those muscles around that particular area, ensuring that you are functioning correctly. Obviously, you're feeling a lot stronger before maybe long term, maybe if your bone mineral density has improved or increased or functionality, under supervision, these types of exercises could be possible down the track. But again, it's really going to be, I guess, monitoring from your exercise physiologist. So yes, if you have certain health conditions or particular injuries in the past or current ones that are affecting you, it is really important that you do seek, I guess, allied professional help. So thanks for the great question.
The final modality of exercise was our balance training and falls prevention. A fall is defined as an unexpected event in which the participant comes to rest on the ground, floor, or lower level. It's quite a graceful definition.
Yeah.
We know that over 1/3 of Australians over the age of 65 fall one or more times every year. This can lead to consequences such as minor injuries, hospitalizations, hip fractures, permanent disability, and death, unfortunately. And it has an extreme burden on the health system. So a single fall can range between $1,600 to $5,600 each on the healthcare system. But the positive is that falls can be prevented through exercise, and the risk of a fall can be identified by assessing individuals' strength, primarily through their lower legs and their lower limbs, their walking patterns, so also referred to as their gait, and by doing specific balance assessments. So when we're training our balance, there's 6 different components that we want to be looking at. Strength is number 1. We definitely need to have strength to be able to have balance. We also want to be looking at something called power, which is our ability to produce force at a fast pace. So if you are having a near fall event, you want to be able to have the strength in your leg to catch yourself, but you want to be able to move your leg to the right position fast enough to catch yourself as well. You want to have coordination, so the ability to move our limbs freely in space at alternate times. Stability around all the joints and areas of the body. Using my fall example before, for reaction time again, being able to move fast enough for that reaction, and confidence. And I cannot stress confidence enough. Having confidence in your own body and in your own mind about your legs and your ability to catch yourself if you do fall, or your confidence in your strength, is of paramount importance. So when it comes to prescription for balance, we know we need to be doing at least 2.5 hours a week of exercise. And what's really important is it has to be challenging exercise. As you can see, Nicole is demonstrating some balance exercises here.
Try.
But if you're doing a balanced exercise that you find relatively easy, chances are it's not going to be having a great effect on your body. So we need to make sure they're challenging, 2.5 hours every week. But note that 2.5 hours can include your strength training.
So Keiza, so hopefully majority of you already training at a Keiza. I guess currently what we offer is obviously qualified, experienced exercise physiologist, obviously with a science-based approach. The effectiveness and efficient strength training. So again, starting with 2, progressing with 3 sessions per week. We offer bone loading training, so our break-free program, individualized exercise programs tailored around your certain capabilities, high quality machines, which offer a safe, risk-free way of training, adapted to all ages and goals, and most importantly, muscle isolation, working on posture, balance muscles, and injury prevention. So Tim's in one of these pictures. So as you can see, these are just some specific machines that we do offer and we do have that are really going to target around the neck and femur, the lumbar spine, and the wrist too. So you've got the back machine, again, all very safe. We do want to prevent, I guess, a full range of motion, working within a safe, comfortable range, preventing kind of extreme shear forces or loading compressive forces too. You've got the leg press, which we can adjust the backrest to also again change the angle of load through that neck and femur. We've got some hip stabilizers, hip stabilizers. So the A3 working on the glute med, and then we've got some hand ones, and the D6, which is the chest press, loading up through the wrists.
So in combination with the one-on-one training, we do have 2 forms of exercise physiology group classes that are running within Keiza. The first one is our break-free program. And this class pretty much focuses on the impact side of things, so the weight bearing and plyometric exercise. And everyone in that class has an individualized program for them, done in a group dynamic and done coincidingly to their strength training. And note that this can incorporate some form of balance work as well, depending on the individual. We also have our stable and able class, which is just primarily balance work, taking into consideration all those 6 components I went through a few slides previously. What's important to note is you may be thinking that you are eligible for both, which is definitely true, but your exercise physiologist will determine which is the most appropriate one for you to begin with.
Yes, at the moment, I think a few centres or clinics are running them online, but fingers crossed, we'll eventually be running them in person soon. So that brings us to a very exciting special, the June Exercise Physiology offer. So if you mention, or if you attended tonight, if you mention that you attended this webinar, For the month of June and June only, you can complete a no-gap initial assessment with a Keyser exercise physiologist, and this is Keyser-wide. So yes, the month of June, if you haven't seen someone before, or if you're wanting to, I guess, see us again, it's a no-gap initial assessment. So that brings us to the end.
Thank
you.
you.
Thanks, everyone.
Thank you so much, Ben and Nicole. It's so informative to hear two experienced clinicians talk about that topic. And I think I can speak for the 95 people that we've got on here that took a lot out of tonight's session. There are a couple more questions which I thought we'd answer. And the first one I want to start with, because I've just checked it via email. Laurie Parker has sent an email through to Pia today and asked a question. And I must admit, Laurie, I read the email. I wasn't exactly sure of the question that you're asking, but I think what you're asking is, do I need to do diet or take medications or take supplements or do exercise, or can I just do one of them? And I think the answer here is that those conservative approaches, like getting an appropriate diet and doing the appropriate exercise, is the first step that everybody should take once they've been diagnosed with osteoporosis or osteopenia. The need to go down the path of medications is something that you would discuss not with a physio or an exercise physiologist, but you would discuss with an endocrinologist and or your GP. And in a lot of cases, you need to make all of those changes, but certainly not every person who gets the diagnosis needs to start medication straight away. Whereas if you get the diagnosis, starting strengthening exercise and managing your diet straight away is a really good idea, because the secondary effects of that are really positive. It's going to help your blood pressure. It's going to decrease your pain and decrease everything else as well. So yes, you should start those two. No, not everybody needs to have medications. I'm going to tick through a couple of other questions. How many jumps on the box would be beneficial? Ben, Trudy wanted to know.
No, that's going to be dependent on the individual as well, but there's not going to be a specific number that's going to be most important. It's going to come down to the technique of those jumps as well and how they're performed. And that's something that I guess your practitioner can teach you and then prescribe the appropriate amount depending on your situation.
Trudy, I can give you a bit of a ballpark. There's two really well-known studies in bone density. One was done in school children. They asked kids every day to jump up and down on the spot 10 times. And there was another well-known study called the German bed rest study, where they had people lying in bed and they took one group out and they let them do jumps each day and they measured their bone density. And what they did with those guys was 3 sets of 10 jumps and 2 sets of 10 hops. So that gives you a bit of a ballpark of the type of number that we might be talking. And both of those studies showed positive results for bone density or retaining bone density. But definitely the exact number that's relevant for you. I know I look at my mum, who's in I'm not sure if mum's on tonight, but mum falls into a high risk category for osteoporosis. And I would not allow her to do 30 jumps per day every day starting tomorrow. It just wouldn't be appropriate. She'd end up with an Achilles tendinopathy before even worrying about bone density. So that's what Ben's talking about, taking different things into account. Nicole, have you seen improved DEXA scan results from people using your program?
Yeah, definitely. I don't know one off the top of my head, but we've had, I guess, at Keyser Malvern, an array of individuals who've seen, I guess, really great results with their DEXA scan and bone mineral density. Majority of them had taken, I guess, advice, so Pia and myself, of committing to a 12-month, I guess, Keyser intervention. So where they didn't take any medication, they solely focused on committing themselves to training starting at 2 sessions per week and then moving to 3 times per week. It's obviously, it gives us a lot of joy when we see them again, obviously every 3 months or however long we see them. But once they get their next DEXA scan, we always catch up and compare the results. We've had a number of people who have seen improvements and actually been quite surprised on the effect that Keyser as a sole intervention has had on their DEXA scans.
That time frame is a really important one though, isn't it? Because You know, I treat people with tendinopathies and with arthritis pain, and I think we can see improvements in that in a much shorter time frame than what an EP can for osteoporosis, because it's going to be 12 months before you get another DEXA scan. And so you need to be consistent for that whole period, don't you, Nicole?
Yeah, exactly right. It's definitely a commitment. I guess as EPs, it is our, job to actually educate individuals on it is going to be a long-term thing. It's not going to happen overnight. It's not going to happen over the first 6 weeks. It will happen over a few years, and whether, they believe us or whether they take our advice and actually do it before, heading down kind of the medical pathway to use medicine.
Guys, we might call an end to this evening now. It's a couple of minutes past 8. We will send an email out with a copy of this webinar and with a couple of other links. And I just wanted to make special mention tonight to one of our audience members, Beryl Logie. And Beryl, I'm doing this without your permission, but Beryl's been a really big supporter of Keyser over the last 10 years. And I know it's 10 years because I attended one of Beryl's events in a church in Camberwell with Paul Percy 10 years ago when Beryl first started. And Beryl also looks after the Melbourne Osteoporosis Support Group and does a fantastic job promoting osteoporosis, promoting Keyser. She's a very big advocate of ours, but also supporting all those people that have been newly diagnosed with a condition that sometimes is hard to find a little bit of information about. So I might seek Beryl's permission, but we also might add a link at the bottom to the Melbourne Osteoporosis Support Group because they're a wonderful organisation. Beryl's a lovely lady and been a great supporter of ours for plenty of time. So if anyone has got a question that has been left unanswered, Carlo and myself will share them with Ben and Nicole and make sure that they do. We will have another webinar on a slightly different topic. Benny Ansell will be talking about golf next Monday. But we also had a question tonight about osteoarthritis. So I'll do my best to organise a presenter for arthritis. And that might be one of the other topics that comes up in the next couple of weeks. But thank you everyone for coming along tonight. Thank you, Ben and Nicole, for the power of work that you've put in. Good luck, everybody. Keep strength training, stay strong, and we look forward to seeing you back in the Keyser Centre soon.
Bye, everyone. Thanks for joining in.
Thank you, guys.